Good afternoon. My name is Wendy Melland. I'm from Kansas City, Missouri, and we are just thrilled to have you here this afternoon. Our next topic is tips and transitions for caregivers of children with medical complexes. Our first speaker, or we have two speakers here, Michaela Ibach. Dr. Michaela Ibach received her bachelor's degree in biology from Covenant College in Georgia and her medical degree from Rutgers, New Jersey Medical Center. She completed her residency in pediatrics at the Monroe Carroll Jr. Children's Hospital at Vanderbilt and a fellowship in palliative care at the Helsinger Palliative Care Center in Akron before returning to Children's Hospital in Nashville, where she is now on the palliative care team. She is also an assistant professor of clinical pediatrics at Vanderbilt. Sarah Wilkerson earned her BSN from Middle Tennessee State University and her MSN from Vanderbilt University, where she is a pediatric nurse practitioner. She specializes in pediatric complex care on hospital medicine team at the Monroe Carroll Jr. Children's Hospital. So thank you for coming today this afternoon.
Thank you for having us. It's good for Sarah and I to be here. We are glad to get to talk with you today. I was going to start off by introducing ourselves a little bit. Hello, my name is, but that's been done, so that's great. And I know for all of you out there and all of you listening later, I wanted to just kind of get to know you out there a little bit. But I think we'll probably skip that part, so I'll just welcome you to Nashville first, and just want to say that it is really a privilege to get to be invited to speak here, and hopefully we can make this as conversational as possible, especially with a little bit of a sparser crowd this afternoon. I know it's a nice Friday, so that's great. But we want this to be a conversation, but we also here at the beginning want to acknowledge everyone involved, everyone at this conference. We know that caregivers for those with mitochondrial diseases are amazing. We know that you are hardworking, you are tireless, you're probably also tired. We know that not just your emotional energy goes into this, your physical energy, spiritual energy, your whole person, lots probably goes into all this. We know there's a lot of emotional demands, that there can be guilt, worry, fear associated with being a caregiver of someone with a mitochondrial disease. So we want to acknowledge that on the front end and to say thank you for doing what you do. A couple other caveats before we get started. We are both pediatrics providers, so we're going to focus mostly on pediatrics knowledge. Hopefully that will be helpful for all of you. I'm going to start things off by giving some tips for communication with the healthcare system, and then throw it over to Sarah, who's going to talk a little bit about transitioning from pediatric care to adult care. We'll both introduce our specialties in case there's any of you out there who aren't familiar with either palliative care or complex care, and then we'll launch into the rest of the discussion. Maybe just by a quick show of hands, how many of you out there have children that you're taking care of? Okay, most everybody. Okay, good. Adults? Anyone caregivers for adults? No. Okay, good. Okay, so great. So you're in the right spot. And then the final caveat I would say is that we know that probably a lot of you could be up here giving this talk just as well, if not better, than us. And so we are speaking from our own experience and working with lots of different families and with lots of different types of either serious or complex illnesses. So take what's applicable to you, but if you find that what you're doing is already working, then just let it go out the other ear. But we hopefully will be able to add to your already excellent care of the children or loved ones that you're caring for.
At the end, we made a Google poll, so we learn a lot from our families. We would love to hear some great tips that are working for you guys. If you feel so inclined to log in to the Google poll and leave us some tips and suggestions, we would love to pass that on to our families.
Yeah. We learn as much from our families as, well, probably more than they do from us. Sarah, you want to talk about complex care?
So I work with the complex care team at Vanderbilt Children's Hospital. We follow kids with multi-system, lifelong chronic disease. We partner with families to navigate the Vanderbilt healthcare system and work together to provide goals-directed care for your child. We have a pretty big team, as you can see below. And when I say partner, that's really what our main focus is. We know that you know your child the absolute best. We are pediatricians trained in the care of children with medical complex needs. However, we understand that no one wrote the book on your child. So we strive to make it a priority to listen to the things that you need to give your child the best life that they can have. And then we also strive to provide a continuum of care for your family. So we kind of see patients wherever they are, wherever they enter the Vanderbilt system, to kind of provide a familiar face, because I'm sure many of you all take your children to teaching institutions, so you see a new face every day, and we try to provide that continuity. Oh, yes, sorry. So this is just an example, actually, a patient of mine, kind of before they were enrolled in complex care program, all the specialists were talking to her, the mother, but no one was talking to each other, and she drew this nice diagram. After complex care got involved, everyone was communicating and talking to each other, and we were kind of the go-between with that.
How many of you out there are involved with a complex care program at your own institution? Okay, good. How about palliative care? Involved with anybody? Okay, a couple of you. Okay, good. Well, there's a lot of overlap in both of what Sarah and I do, just with different flavors. So palliative care often gets a bad rap these days. We're working on changing that. How many of you have like a negative reaction when you hear palliative care? Maybe thinking hospice, end of life? Yeah. We're working hard to change that, because we're not just end of life. I like to describe, whenever I meet a family, I say palliative care is a specialty within pediatrics that helps children with either life-limiting, life-threatening, or serious illnesses live the best life they can for as long as they can. We seek to support the whole person and the whole family, so spiritually, emotionally, physically, behaviorally, developmentally. And we are a board-certified medical specialty, so complex care is, I think, working on that, but we have a board certification exam. So they mentioned earlier, I did my fellowship at Akron. I see a lot of you have Akron Children's Hospital on your badges, but that's where I did my fellowship last year, and I'll take the boards this fall. And so I'm a pediatric doctor trained in palliative care. All right, so what does that exactly look like in practice? So to kind of put some more teeth into that definition, so we do pain and symptom management, right? If we're taking care of the whole person, we want to make sure that we're caring for them physically. Navigating goals of care, what this really means, I know that word goals of care probably can give some of you a visceral reaction too, but all that really means is what's important to you, what's important to your family, what are you hoping for, what are you worried about, what things are on your mind as you think about medical decisions for your child. And then along those lines, often you probably know, but there are decisions in this journey of healthcare, and how do we make decisions that line up what's important to your family, your goals, and what is and the medical options out there. So that's where we come in and try to fit or build a bridge between what's important to your family and the medical decisions we're making. And then you might imagine that we have to communicate those things, both what's important to you and your decisions, to other people, whether that's other people in your own family or whether that's other members of the healthcare team or even your child. So we assist with complex communication where it's necessary. And then transitions in care, the one everybody thinks about is hospice or end-of-life care, and we do that. That is part of our field, but we also transition people from different units of the hospital. We serve as a continuity piece, just like Sarah said, too. We go wherever our patients are, so that means from the ICU to the floor, making sure that goes smoothly, or from the floor home, whatever that looks like. So that's sort of how we do it. And I really like the bridge analogy. We're building a bridge with from your goals to meeting your goals with healthcare. We like to be that bridge. And what pediatric palliative care is PPC, what it is not. So hopefully you figured out that we're not just hospice and end of life. We do a lot more. We can get involved anytime from diagnosis to either cure for some children, or end of life, or transitioning to adulthood. Speaking of that, we are also not the same as adult palliative care, so a lot of you maybe are thinking more along the lines of that. Similar in philosophy of maximizing good time as much as we can for as long as we can, but executed differently just by the nature of the parent-child relationship, and the healthcare systems are a little bit different, and I know you all know that since you're taking care of your loved ones. But so we're not the same as adult palliative care, and we also are not, let's see, what else are we not? We're not complex care, although we do overlap, like we said. And I think if you need a framework for what we both do, sometimes together, sometimes separately, is we help you give bricks to build bridges, and also tools to put in your toolbox to help you take care of your child in the best way possible. Palliative care and complex care are also, I'll say this caveat, a lot of you raised your hands when you said, are we involved in one or the other? We're not the same at every institution. So each children's hospital sometimes has both, like we do here at Vanderbilt. But for example, at Akron, where I did my fellowship, complex care and palliative care were essentially the same thing, and that just comes down to how the teams grew and what the resources were. So you, depending on where you seek care for your child, you might meet one or both of us or none of us if that's something that maybe your institution is still working on. So that's sort of what we each do in our specialties. Okay, questions about that before can you all hear me okay? Okay, I should have said that earlier. All right. So like I said, we're going to talk about tips. Sarah's going to talk about preparing for the future. I'm going to talk first about communication. We'll talk a little bit about self-care, because we know that's hard even for us.
And care of the siblings.
And care of siblings.
Gets forgotten then.
So, and again, before I go into all of this, I will say, again, you might be really good at a lot of these things. You've probably learned a lot about navigating the healthcare system. And that's what I'm going to focus on. I'm making the assumption that some of you have had maybe not the best experiences with communicating with the healthcare system or interacting with it. I know that there can be a lot of frustration, specifically with information gathering about mitochondrial diseases, or lack of knowledge felt like from the medical providers, or you can just feel like you're out there with a lot of questions. I know that can be early on, and then wondering about prognosis. So, and then even for families without children with complex or serious problems, there can be a lot of barriers to communicating. So hopefully what I say will be helpful. Hopefully it won't be too abstract. Hopefully I can give you some tools to put in your toolbox. But if everything I say you feel like, hey, I've already got that down, I already know everything she said, then great. Do what you're doing and tell other people, because I think all of this hopefully will be applicable. Okay, so I start off with communication with yourself, and I know you all are probably very self-aware, but a lot of people aren't, and I meet them every day, and I'm getting better at this too. But I like to ask families a few questions when I first meet them to get a sense of how they communicate. I think that knowing how you like to get information and awareness of what your own communication style is helpful as you approach others in life, but then also the healthcare system. So specific questions that I think are important to know. How you best receive information? Are you a details person, or are you big picture? Do you like written information or oral, which is better for you to learn? And then how far ahead do you think just naturally? Are you a down the road kind of person, or are you a one step at a time? And I'm sure maybe all of you kind of figured out in your head. But I meet families who one of the parents may be able to look way down the future. They are crossing every bridge. They are taking every fork, going down that fork, crossing those bridges, taking those forks, and can do that. And other people, that makes them anxious, and they just need to look straight down and just take one step at a time. So I think having an idea about these questions in yourself might help you as you approach healthcare providers. Okay, so what else is good to know? Your history, and by that I do mean your child's medical history. You know, that's kind of the start to finish, but it's, the specifics too, their surgical history, their seizure history, their feeding history, whatever that looks like. Yes, that all is important. But I also think it's also helpful to know your history of what types of interactions have gone well with the healthcare system and what types haven't. Again, going back to awareness here. And I don't want to trigger any traumatic experiences for those of you who maybe have had less than pleasant interactions with some healthcare team members in the past. But at least awareness is the first step of any process. And so knowing what's happened in the past and what's gone well, and then kind of at least being aware in the future if you're feeling like you're in the same type of situation. What do you value? That kind of goes back to goals. So what's important to your family? Maybe it's pursuing health or medical interventions at all costs. Maybe it's being at home other than being in the hospital. Maybe it's making sure that your child or loved one has the biggest voice that they can in their healthcare decision making, or maybe you have religious values that play into how you make medical decisions. I think having an idea of what your family values is important as you think about how you interact with healthcare. And I don't mean to say that if your child has pink eye and you bring them to the doctor, you don't need to say, okay, well, here's my religious beliefs, and here's everything I value, and here's our long-term global picture. So you don't have to know all this every time, but I think having, again, awareness is important, at least for those times when it will matter in sort of the bigger decisions or the bigger forks in the road. Other questions here that you all maybe think through on a daily basis or don't, but they might be things like, what are you hoping for? What are you worried about, afraid of? What things are important to your child? What does a good life look like for your child? Those kind of things that kind of get at what you value. Okay. So communication with yourself, now that we know that, now we can start thinking about what does it look like to communicate with the healthcare team. And I am going to kind of frame this in thinking about who's who on the team, who's doing what and what are their roles, what's best, what information to share and when, and I'm going to give a word about certainty. And then on the next slide, I get into more practical ways to apply this. But to kind of stay on this slide for a second, I have a friend who is really into details and really into nitty-gritty things, and every time I'm a little bit more of an abstract thinker, and so every time I'm going to go abstract, I have to warn her and say, okay, abstract alert, take yourself from down here and go to the 10,000-foot view. So this is your abstract alert. These are generalizations. That's why they're generalizations. They're generally true, but they're not always true, and that's okay. But the things I'm going to say even have helped me as I communicate with other people in the healthcare team, because I get frustrated too. Again, I'm assuming that this is based on past frustrations. Because I think we all could communicate better. But it's a reminder that I can't change other people, right? I can't make people work faster. I can't make someone return a call faster. I can't make them listen better. But I can change my mindset, and that can be helpful. If you're already doing all of these things, or you found your way that works for you, great. Keep doing it. But I do want to foster empathy and respect both ways. And I might be preaching to the choir here, and trust me, if we were in a room with healthcare providers, we'd probably be doing more talking about communicating with families, because I think we probably do a worse job of that than you to us. But that's sort of my abstract caveat. A little bit more framework about who's who and what's best. So who's who, what are the roles? Who's on your healthcare team? What are their roles? Are they a physician? Are they a nurse practitioner, a PA, physician's assistant? Do you have a social worker, a case manager, a therapist? Who's on your team? Genetic counselors, whoever it is. And then what do they do? So a social worker isn't going to have the same role as a physician. They're just not. And so if you ask a social worker something that you should be asking your physician, you might get a little bit of a runaround, but that's just because the nature of their role on the team is different. Or you might feel like you're getting a runaround, I should say. What's best? That kind of means what's best to share and when. That kind of gets into knowing your medical history. You don't need to pull out the A to Z every time, but there are appropriate times to talk about certain things and not others, probably. I'll go back. Or I'll kind of to go back to the pink eye example, I guess. You don't need to know your seizure history to talk about pink eye, but you might need to know which medications your child's on and then how the pink eye medicines might interact with those. So it's important to know what's best and when. And like I said, I'll give some practicals next. But a word about certainty, I'm guessing, but I think in this community, and for a lot of families, not just in the mitochondrial community, but just the way our culture teaches us to think about medicine, we'd like it to be more certain than it is. I think you all probably, and I do too, when it comes to my own health, we crave certainty. We want to know definitely what is going on and definitely what is not going on. And I don't think a lot of medicine works like that, unfortunately. I wish that it did. There are some things we can be certain about. There are some things that we can be certain are true and certain things that we can be certain aren't true. But for everything else, when healthcare providers are faced with a problem, we are taught to list out everything that could be wrong or could be going on and rank them from like the number one likely thing that it is to the number whatever likely thing that it is, and then use evidence, so our labs, imaging tests, things that we find, and try to narrow things down. So the goal is to get as small of a list as possible of those things that it could be, and then act on the number one thing on that list until we're proven otherwise. So notice in there I never said we have a definite thing, right? Unless it's a thing that we can be certain about. But for a lot of things in medicine, that's how healthcare providers are trained to think. And what that means is that we'd like things to be cut and dry, but a lot of times we're acting off of what is most likely instead. And that matters, I think, because I think a lot of lay people who aren't in the healthcare profession, that's a piece that's taken me time to even understand. As a healthcare professional, I think that sort of lack of certainty or more operating on most likely is a little bit, might be helpful for you all as you're thinking through that. And usually that's a good thing, right? We don't want a physician to assume, hey, I know exactly what's going on 100% of the time. We always want them to be thinking, well, what if it's something else? What if I need to be doing something else to help this person better? We want them always questioning themselves. So usually that's good. But for those of us out there that want certainty, it can be a little bit harder. But that's sort of my last abstract thing before I get to practicals. Thank you for being patient with my abstract alert. Okay, so some bricks. This slide is a little bit out of order than what I decided to talk about it about, but I think going back to who's who here is important. So that's even knowing what environment you're in. So are you in the emergency department? Are you in a doctor's office? Are you going to see that doctor again? That type of thing. If you, to give an example, let's say you go to the emergency department with your child or loved one. They, for some reason, have a cut, need stitches. It's something basic, but they also need their seizure medication refilled. You might ask 5 people, hey, can you help me get my seizure medication refilled? 5 people are either going to ignore you or tell you no, and you're going to probably get frustrated. But it turns out you probably talked to the secretary or medical receptionist who can't do that, the paramedic who can't do that, the person walking you back, the nurse who's probably really well-meaning but also can't do that, and the physician who is going to stitch up your child's arm and doesn't have the knowledge to refill the seizure medicine. So I think knowing in that situation who everybody's roles are might help and maybe save you a little bit of aggravation when asking questions. I think to get around this, a tool for your toolboxes might be to ask who's the best person to talk to about X, Y, or Z. So who's the best person I should ask about having my child's seizure medication refilled? That might be a good way to go about it, because then you'll get an answer, and hopefully that person will know that and can get you that answer. So who's who, that also kind of goes into when to ask things as well. I think finding your co-advocates is also important, and by that I mean, you all probably can think of the people who have helped you the most or have made the healthcare navigation process the most helpful. They're advocates with you for your child. They're the ones that answer your phone calls. They're the ones that help you find what you need or get what you need. We try to be that for our patients. And I think everyone on the healthcare team wants to be that, but just with the nature of healthcare, not everybody has the role to do that. So find those people. It might be a physician or a nurse practitioner. It might be a social worker. It might be an RN. When you're on a certain floor, you know that that's the person who's going to help you. So know who they are and then use them appropriately in their roles. So find your co-advocates. Have some communication tools. I said that one earlier about asking who's the best person to talk to you about X, Y, or Z. Some other, I think, other language that I think is good always in general communication with people, but using I phrases that doesn't put anyone on the defensive. You're like, I don't think I'm quite getting what you're explaining to me. Can you say it a different way? Or I don't understand that. Can you please explain that again? I wouldn't feel. I wouldn't get on the defensive if anyone starts using I phrases. I think that's helpful even in personal life as well. And then I think other concrete things, like at Vanderbilt we have family information notebooks or a 3-ring binder with pre-populated with pages about health history, school history, medication history. You can put basically anything in there about your child that you want that would be important, and you can take that around to different healthcare systems or different providers or the different settings that you're in and use what's important in there. So you might have a page that outlines your child's surgical history, and it's important for when you go to surgery appointments. Or you might come to one of us and we want to read the whole notebook. But it's another tool for you to have to know what's best to share when. And then, let's see, ask. So ask. It is okay to ask. I want to make that clear. We want families and caregivers to ask us the questions and their worries and their wonderings. We want that. But for those who maybe are a little bit less, or maybe put up some nonverbal communication that maybe they don't want you to ask things, I think it's okay to ask permission to ask. Is it okay if I ask you a hard question right now? Or is it okay if I ask you about my child's X, Y, or Z? Ask. If not, who can I talk to about that? I think that can go a long way. I think there is a balance between being the squeaky wheel and catching flies with vinegar instead of honey. But I think if you err on the side of the squeaky wheel and use your co-advocates and know what's important to you, I think that'll go a long way. let's see. Oh, and then asking, so going to go back to certainty here. Asking, so how do you, if you want certainty and you might not get it, how do you ask about that? I think that the way to do that is to just ask the healthcare professional, is this something we can be certain about, right? They're going to give you a yes or no. If they say yes, okay, what's the answer? Are we certain or are we not? Or is it or not? But if they say no, it's not something that we can be certain about. In those cases, I think the way to get at the next thing that you want to know is to say, would you be surprised if? So can we be certain? If the answer is no, we can't be certain. Would you be surprised if X, Y, or Z happened? That will give you an idea about like sort of the likeliness of something. So would you be surprised if this seizure medicine didn't work? Sorry, I keep going back to seizures, but would you be surprised if my child needed a G-tube in the future? Would you be surprised if my child's health declines within the next year? And you can kind of get a better sense of sort of where you are on the certainty spectrum. I'd be careful of doctors who give you percentages. I think with some things that's okay because that sometimes works out. But especially with rare diseases, we just don't have the numbers to be able to give percentages. I think the certain or uncertain question is, or surprised or not surprised is a good way to get at that. So, and then finally, practicing awareness and decision making. By this I mean we already know that you know your values, you know what's important to you, and so how do we apply that? What I mean by this is, we all do this every day, right? We get up and we make decisions every day, and a lot of times we're doing a risk-benefit analysis constantly. And I'm an overthinker, and so I get paralysis by analysis all the time, and I don't want any of that to happen to you. But even if you start thinking in terms of, do I want to sleep in today, or is it important to get up? You probably all never sleep in because you all are tireless caregivers. But, I want to send my child to school today. They have a field trip that they're really looking forward to, but they had a runny nose last night, and they might be getting sick, right? You're just being aware that you're making a decision like that might help you as you make bigger and bigger decisions if you have to in the future. So don't go crazy, don't drive yourself crazy, but even just thinking, here is how I'm making decisions, here are the values I'm applying. When you hit a big fork in a road or a bridge to cross in your child's health care, you might have a little bit easier time in building a framework for how you think. So I think that's all for communication with the healthcare system.
Leave
it on this one?
Yeah, just for a minute.
You got it.
So I'm going to talk a little bit now about transitions from pediatric to adulthood. Only one generation ago, 90% of people with severe disabilities did not live into adulthood, and now about 90% survive into adulthood. In 2010, there was a consensus statement on healthcare transitions of young adults with special care needs was adopted by policy by the AAP to help realize the vision of family-centered, continuous, comprehensive, coordinated, compassionate, and culturally competent healthcare system that is developmentally appropriate as it is technically sophisticated. So it's a great vision, but it takes a lot of forethought on the side of providers and families to make this come true. And so when you're thinking about transitioning care for your child to adult providers, ideally it would start to happen a couple of years before the planned time. So 18 is going to come really quickly, so it's good to really start thinking about this when they're 16 and start talking to your pediatrician and your specialty providers about what the plan is for transitioning to adult providers. You need to identify support people that can help you with this transition, so like case managers, social workers, and then part of starting really early in the process is so that your pediatrician, your specialty providers can be getting care plans together. You want to be able to go tour the facilities, meet the providers. And then another huge important piece is once the transition is made for your providers to be willing to keep an open line of communication, because that's 18 years they've had with your medically complex child, and that's a long history to just pass off to an adult provider without having any open line of communication so they can call back and with questions. And so I think that's okay to ask your providers, is this something you're going to be able to do for us? Are you going to be available for a little while after we transition to be open to communication with another provider. And then if you're writing down notes on your paper, there's a really good federal agency. It's called GOT Transition, Center for Healthcare Transition Improvement. It's a cooperative agreement between the Maternal and Child Health Bureau and the National Alliance to advance adolescent health. And their aim is to improve transition from pediatric to adult health care through innovative health strategies. And it's a really great resource and webpage for some frequently asked questions about transitioning to adult care. So another thing to think about when your child turns 18 years old is to apply for SSD, which is Social Security Disability Benefits. Prior to 18 years old, the financial assets of the family weigh a lot more heavily than they do on an adult child that's 18. And also, I would say that so to start the process to schedule your interview with Social Security, it can take place immediately after your child turns 18, but you can call before your child's birthday to set up an interview. And you can go to the Social Security office closest to where you live. You can go online. And if you want to ask questions beforehand, I'd recommend doing that before they turn 18. And then often your child will be denied SSDI benefits, but you can appeal multiple times, and the more times you appeal, the more likely you'll be able to get in front of a judge. And sometimes putting the family spin and seeing you face to face can really go a long way in front of a judge. Oops. And so once the child qualifies for SSDI, you can apply for Medicaid benefits. And then sometime between 21 and 22 years of age, once, yes?
So I did this with my son.
Yeah.
And it was incredibly easy.
Okay, good.
And so I wonder if in this community, because most of our children are really disabled.
Yes.
If it's not something, it appeared to me, and talking to some other families with autistic children and other children disabled from birth,
Yeah.
it seemed like this was not an area where there's tremendous fraud. It's
Mhm.
hard to take, but who would want to?
Right. Right.
So that was just my experience.
I'm so glad to hear that. And I think it varies state to state. And I definitely know that under 18, there's a lot more heavy influence on the spend down and how much income you make. But once your child is an adult, then they look a lot more at the disability. So that's another thing. There's going to be a lot of questions. And to start thinking about that early and calling the office and looking on the website and just really getting some information. Yes, ma'am. Yes, I'm sorry, you're right. Yes, so SSI, you're right, or have a disabled parent. Yes, yes. I think that you.
In the other class, I'm sorry.
Yeah, go ahead.
Right before this, he said that if the parent is retired, deceased, or is disabled, then the person can get SSDI off of the parent's Social Security. Otherwise, it's SSI.
Yeah, thank you for clarifying that. And then, so once a person is transitioned to Medicare, Medicaid has a lot of benefits, including private duty nursing that are not as available with Medicare. But Medicare also has some benefits in that, in Tennessee, at least at Vanderbilt, adult providers will not see patients with Medicaid, but they will see patients with Medicare, and that differs from state to state.
Sorry, I have another question.
Mm-hmm.
So I've been trying to
Mm-hmm.
The card just came in the mail.
Mm-hmm.
And I thought that after 2 years on Medicaid, you get Medicare.
Yeah, it happens sometime in between 18 and 21, 22.
On supplemental security income, you do not get Medicare. It's only if you're on the SSDI.
I believe that's true.
Okay.
I'm sorry, I don't know the answer to that, but I'll be happy to look into it.
Okay, only because
Yeah.
I happened to talk to somebody at Social Security last week because I made a mistake. My son works a few hours at a convenience store,
Mm-hmm.
and I was not reporting that income to
Mm-hmm.
and I didn't know I was supposed to. And I'm trying really hard to figure out how to get him on SSDI, which is way more beneficial than supplemental.
Right.
And so they explained to me the credits, and then it's super. I mean, it's super complicated.
It is. It's very confusing. And so I would say if you have a social worker that works in your hospital or whatever point of care your son goes to most, I would ask for them to call you, and they can really break that down. And after you've had a conversation with somebody at the Social Security office and have written down all your questions, they can help break that down. Because like you, I mean, I'm a nurse practitioner, and so I know the basics of timing of when to do it, but we really rely on our social workers, and they are happy to do that. That's what they sort of do all the time. Yeah.
You're the who's who of who.
Yes. Let's see. Sorry. So I'm going to talk a little bit now about several options for legal guardianship. So when your child turns 18 years old, you'll need to decide what kind of legal guardianship is best for your family. And then we kind of strongly recommend that before this time, you will decide who will take legal guardianship of your child in the event that you or your spouse pass away. So there are several options. The first one is conservatorship. And conservatorship is a court-approved and court-supervised legal relationship between a competent adult, known as a conservator in Tennessee, as a guardian in other states, and an adult who needs assistance in decision-making. So this is the most restrictive choice. The court has final decision-making responsibilities and authority in these areas, such as health care, living arrangements, and other finances. A conservator acts as an agent of the court. So there are a lot of costs associated with conservatorship. Just for example, costs for filing initial petition to determine capacity, attorney's fees, physician fees, accounting fees, etc. Another option is a healthcare surrogate. So healthcare surrogate is an adult who's appointed to make healthcare decisions for individuals that can't make decisions for themselves. And this is different than conservatorship because it's appointed by a physician or a nurse practitioner, and you have to reapply or refill out the paperwork every time you are in a healthcare setting. So the proposed surrogate reasonably appears better able to make decisions for the wishes of the patient and in accordance with the best interests of the patient. And this is listed under the Advanced Care Directives tab on your government's website page. So for healthcare surrogate, the physician, not the individual, decides whether a surrogate is needed and who will take on that role. And here are the preferences for who's chosen. And then a third option is a durable power of attorney. That's a legal document that gives someone authority to make decisions on the behalf of another individual. And so in order for this to be valid, the individual must be considered competent at the time that he or she signs the documentation. The durable power of attorney, yes. Oh, really? Tell me about that. Wow. Yeah. No, and most hospitals should have legal counsel that you can contact in a situation like that to get some advice on what is still within your right, even though he has a durable power of attorney.
Did you sign the
Well, that was my workaround. We have a stamp, and so I took the document and stamped his name on it.
Yeah.
Yeah.
Emailed it to him and said, okay, sign it.
Yeah.
That is a pain.
Huh. That's
Yeah.
And
No.
they have a copy of that, the hospital has a
Yeah.
copy of that.
Yeah.
durable power.
Yeah. No, that shouldn't be. Yeah.
It's frustrating.
Very frustrating. Yes, ma'am.
Along the same line, I thought we were covering our bases. My daughter's working for me and has a durable power of attorney, and usually, again, ranking's different in Nebraska versus Kansas, Missouri. But I was told that the durable power of attorney is only if the doctors, and it takes two doctors to deem that they aren't capable of making their own decision, does that come into play? And like for medical records, that in the county, you need to find some other, you need to have some other document like release medical records. So that's one thing I was hoping to find out in this conference or afterwards, talking to attorneys to find out, okay, maybe I just have to print off the internet cheap version, I need to talk to somebody, make sure that we have the right power of attorney, the right documents so that.
Yeah. So at the end, I'm going to talk a little bit about some free legal counsel that's available. Yes. Mm-hmm.
So I have guardianship for my son, and I have the certificate, and I saved it on my phone.
Mm-hmm.
And when I use that, I don't have any problem. I've never tried a durable power of attorney, but the guardianship certificate is done.
Okay.
Is it specifically for healthcare power of attorney or legal power of attorney? Is that, I wonder if that's the, yeah.
Mhm,
Right.
mhm.
So that's, I don't know, it is cheap, a lot cheaper to have the POA.
Yeah.
than Conservatorship or guardianship.
Yeah.
I would have guessed that it is valuable.
So, and I think the group before me talked a lot about special needs trusts. There were lawyers there that were doing that. So I talk a little bit about that, but they are definitely the experts in that. So, you know, the conservatorship is really important if your child has a special needs trust, which I'm sure all of you are familiar with what that is. It's a legal plan for placing funds and assets that are given in the child's name. And the trust protects the individual assets without requiring that they be declared incompetent by a court. So the pros of a special needs trust can keep a person eligible for government programs like SSI and Medicaid and help pay for services and care over and above what the government provides. The funds created are tax deductible. It ensures that the funds are used for the care of the person with a disability, and the funds are not available to creditors for paying off judgments. So you may want to consider a special needs trust if there's a significant amount of money to be left for an individual property or like settlement from a lawsuit. The disadvantages of a special needs trust are cost, annual fees and high cost at setup, lack of independence of the beneficiary, and the Medicaid payback. And so I think that I listened to the last part of this presentation. But so if you're setting up a special needs trust, it's really important to get a lawyer involved in setting it up that specializes in this, because there are third-party trusts that you can set up so that the assets don't allow you to have to pay back Medicaid, which is after the beneficiary is deceased. Some special needs trusts require that all the money owed to Medicaid is paid back from the trust. There's a really great resource that talks about guardianship, conservatorship, durable power of attorney. It's the ARC Conservatorship Handbook. You can download it from online, and it says in a very lay term how to start the process of setting all that up. I'm going to skip through a little bit of this. I think we're running short. There is a new long-term waiver that has recently been passed. It's called the ECF Choices Waiver. It's a Medicaid waiver. You can apply online by completing the self-referral form on TennCare's website. While this waiver focuses on people who have a desire to work, there are also higher funding tiers for people who require more support, including residential services and some nursing and therapies. And this can be used for things like respite, transportation, personal assistance, assistive technology, and stipends for family caregivers. Also, they provide educational training in conservatorship and guardianship, which is really helpful. Yeah, okay, we gotta rush through these. So this is we're gonna get into it just in our last few minutes, a little bit about, more self-care and care of the siblings. And this was a drawing that one of my families did that I thought was very telling and poignant. But the patient is in the middle, and everything on the outside is everything it takes to take care of their child. And when you see it written down like that, I know you guys know it and live it every day, but that's just unbelievable, the amount of things that go into caring for your children.
Yeah, I mean, briefly, hopefully all of you have figured out ways to care for yourselves, but it's important to care for your loved one, to take care of yourself. The basics was normal things like eating and drinking and exercise and sleep. I can tell I like awareness, but being aware of what makes you tick, what you need, when you need what. And then I think, just to kind of go briefly through this, I think it's important to acknowledge the hard things. I don't think enough people do that. I think it's okay to say that it's hard to take care of a loved one with a serious illness. And then also to sit in that, but then also to reach out to people who can help you and to know who they are. That's briefly about self-care. You probably all have a million self-care tips that you could tell us for our next time. You can skip that slide.
Okay.
Oh, actually, go back one. I don't think the Dougie Center is a specifically grief focus. I think there was a talk from my colleague this morning about that. But Courageous Parents Network, have any of you heard of that? So it's a parent group in Boston, from Boston Children's, who made a website for children with all different, or parents of children with all different types of illnesses. There is a mitochondrial diseases section, but there's lots of other types too. But it has resources for thinking through things. It has the stories and just different connections with other parents. But I know you all are pretty well connected. You're here. So.
Let's see. I really liked this. I found this. If you want to know how to treat a child with special needs, look at their siblings. They will show you. So just want to talk a couple of minutes about caring for siblings. I have to say, the siblings of the patients that I care for are some of the most empathetic human beings that I've ever met. So this is a really good article. It was a review article published in 2018 that basically was an extensive literature review that identified several key strategies and interventions associated with better mental health of siblings and children with special needs. And some of the the key takeaways were, that it's important that the illness and treatment not feel like a mystery to the siblings, that it should be tailored to the child's developmental level, and start, by asking what they understand and correcting any misinformation, and then intentionally not telling them about something allows their minds to wander and for them to make up their own scenarios. Also important is one-on-one time with siblings, which I know is often very, very hard to achieve, where it's not about the illness, it's just about spending time with each other. And this obviously requires a huge network of family and friends to help you achieve that. And then maintaining as much normalcy as possible, which is really hard. And then another takeaway, is that siblings learn compassion and empathy toward those who have a disability. And I think that's a huge legacy of children with special needs, is having a sibling that becomes an empathetic individual and just can share that with the world. And there's evidence to support that this experience shapes siblings into resilient, helping, caring adults, which you all know, I'm sure. And then this is the article link. I think it's in your book. And so we just have a few resources. Of course, we're in Tennessee, so we have a lot of Tennessee resources, but I would imagine that most of your major children's hospitals have a similar organization. Ours at Vanderbilt is called the Kennedy Center, and there's a lot of programs for siblings and social work services, help with IEP and vocational training. And then in Tennessee, and I feel sure because a lot of these organizations are nationwide, but there are a lot of organizations that employ children with intellectual disabilities. Vanderbilt does, Goodwill, YMCA, Kroger, the Best Buddies program that allows your child to partner with a young mentor. So here's the ARC Conservatorship Handbook, is what I was talking about with decision making about legal guardianship and things like that and special needs trusts. The Tennessee Disabilities Pathfinder is great. You guys have probably all been on there. And then wherever you are, the Area Agency on Aging and Disability, it also has a lot of helpful tips. And so these are in Tennessee, but again, I feel like in other states all the same thing. The Tennessee Justice Center, they have attorneys that can help appeal Medicaid if there's a denial. And then TennesseeStep.org that helps with IEP in school. So that was it for us. But again, we would love to hear from you guys if you have any pearls, like the gentleman back there that has already kind of been through a lot of the transitions, things that have helped you, and put them on there, share them with the group. Yes, sir.
There's one more thing that
Yeah.
has been just awesome. So I live in New Jersey. I don't know if it exists in other states, but it's called the PPP program, Personal Preference Program. It's a benefit from the Medicaid HMO, and they pay us for caring for our child.
Wow.
Which it's about $1,400 a month.
Mm-hmm.
Really awesome to help care. So you may want to look and see if that exists in your
Tennessee has a similar program. So I think if you go to your local government website for the disabilities tab, you can often find little $2,000 to $4,000 things you can apply for to help pay for things like respite care.
And it's a little bit of a pain. I have to do a timesheet. My wife is the employee. I'm the employer. Zachary is the beneficiary. This whole thing they explain to me, and I'm like, I don't care. How do I get the money?
Mm-hmm.
Right?
Yes.
So, and I have to do a timesheet, just like at work every 2 weeks. But once you get the hang of it and get into a groove, it's really good to have.
That's great. Thank you.
For children older than 18?
I would think so because it's a Medicaid program.
Okay.
So.
I think that's what I've heard. Any other thoughts?
In Ohio, that's called PCA, it's Personal Care Assistance.
Okay.
Benefit to ring, right? My wife's also a nurse, so she gets paid.
To care for your child? That is that's not available in Tennessee, but that is a great, it's a great benefit in Ohio. I know it's a benefit. So that's great because you're doing the work anyways. Yeah. Well, thank you guys so much for coming and listening, and really appreciate it. No, it's been a long day of talks.